Welcome back. It's just gone 19:05. It's that time again. It's a Thursday evening, and that's the time to be on Medical Matters with myself, Dr. Deshni Chonan, and we air every Thursday between 7 to 8 p.m. And today's show is your show. It's a show that brings you all the current events about medical questions that you, the listeners, have been asking us for. And this evening is no different. Today, we turn our attention to pregnancy, an amazing event in anyone's lives. No two pregnancies are ever the same. Anyone can attest for that. It's a period that is both joyous and terrifying, with each stage bringing in it a whole new set of experiences as well as concerns. So this evening, you can join us where we talk to our specialists about all things pregnancy related. So remember, if you have any questions related to it, you can always get a hold of us on 065 4211 380, and that's where we're going to answer all your questions. You can also catch us streaming live on Capital Radio Facebook page, as well as our Radio Garden app, as well as our Mixcloud account. So I'm going to spend a little bit of time introducing my two guests. The first guest I'm going to talk about is Dr. Sumaya Shah. She's achieved her MBB CHB from the Walter Sisulu University in Mthatha in 2004. She went on to do an internship in Pretoria and thereafter returned to KZN, where she worked in the Department of Surgery at Port Shepstone Hospital for many years. Thereafter, she joined the trauma department at the Netcare Margate Private Hospital, where she went on thereafter after discovering her love for obstetrics and went on to specialize at Tygerberg Hospital through the University of Stellenbosch. And she went on thereafter to become a member of the College of Obstetrics and Gynecology in 2018. Joining her is her esteemed colleague, Dr. Nellis Pretorius, who also achieved his MBCHB from the University of Pretoria in 2009. He completed his internship here in Pietermaritzburg and went on to work in Kimberley in the Department of Obstetric and Gynecology. He too specialized in Tygerberg Hospital through the University of Stellenbosch and went on to join the Obstetrics and Gynecology College in 2019. Both of these people are extremely busy people, very, very difficult to get a hold of. I can attest for that. So thank you so much for taking the time to be with me today. I'm very, very excited, especially about this topic. Can you hear me clearly? Okay, give me a second. We're just going to take a little bit of a break and we're going to come right back.
Damn, the doctor's just finished telling me there's no time. Losing you could be the end of me, and that I should do the things that I wanted to. How could I without you, without you? Oh, oh, 'cause you're the only one I let in. Tell me how to stop this feeling spreading. I'm hoping somehow that you know. Oh, oh, oh. Let's just get back together. We should have never broke up. They're telling me that my heart won't beat again. We should have stayed together. No. 'Cause when you left me, it stopped. They're telling me that my heart won't beat again. Won't beat again. It's killing me.
Can you hear me
Hey,
now?
hey, hey.
Yes.
If I die, yeah, would you come to my funeral? Would you cry? Would you feel some regret that we didn't try? Or would you fall apart the same as I? Oh, and would it always haunt you, baby, that you missed your chance to save me? 'Cause you know it's not too late. Hey, hey, hey. Let's just get back together. We should have never broke up. They're telling me that my heart won't beat again. We should have stayed together. 'Cause when you left me, it stopped. They're telling me that my heart won't beat again. Won't beat again. It's killing me. That my heart won't beat again. Won't beat again. It's killing me. Hey, I need you back in my arms. I need love CPR, 'cause it's getting so cold. Oh, I need you back again, or else I never meant. And girl, if I go, I go, I go, I go. Let's just get back together.
Hi, if you're joining me, it's Dr. Deshni Chanan on Medical Matters. Sorry about that. Sometimes we have a little bit of technical difficulties, but I hope you enjoy the music in the meantime. So remember, we're talking all things pregnancy related today. So any questions that you have, please feel free to contact us on 065 Alternatively, we are live on Facebook, so you can get a hold of us on our Capital Radio Facebook page, and you can also hear us streaming live on our Radio Garden and Mixcloud apps. So joining us again is Dr. Sumaya Shah as well as Dr. Nellis Pretorius. Very, very excited to have you guys in. We're going to jump straight into the questions today. One of the things that we all know is very, very important, especially when you find out that you're pregnant, is antenatal care. Do you want to talk to us a little bit more about why it's important, Dr. Shah?
So, antenatal care is actually important to ensure a healthy mom and a healthy baby throughout the journey of one's pregnancy, and to make sure that there's a positive pregnancy outcome. So it depends on your obstetrician. There might be an average between 10 and 12 obstetric visits throughout the 9-month gestation. And during those visits, usually it's a lot of constant medical advice, testing that goes on, lots of ultrasounds that happens occasionally at some visits, looking at the health of the fetus, and obviously then deciding on a birth plan. That is basically what antenatal care is about.
I have a quick
And if
question.
I can just add to that, the importance for us lies in just to getting to know our patient, to know about their history, about their previous pregnancies, their mode of delivery, any complications in their prior pregnancy, as well as any underlying risk factors that is present, like, for example, diabetes in pregnancy, to identify those risk factors and then, to ensure a positive pregnancy outcome.
One of the most important things I've seen, actually the most common thing, is that patients that have been pregnant multiple times feel that I've had pregnancies, I know what to expect. Why do I need to come in for an antenatal visit? So is it still important to do it through every pregnancy you've had?
Definitely, because in your introduction, you also mentioned this, that no pregnancy or no two pregnancies are the same. What might not be present in your first pregnancy might only develop later on, especially something like high blood pressure, for example, or even, again, diabetes that can have dire consequences if it's not treated properly throughout the pregnancy and not identified early.
Okay, so let's just walk it through. For anyone that has never been pregnant before and it's your first pregnancy, congratulations to you. It's an exciting experience. We're going to help you walk yourself through the process. So say I think I'm pregnant. I've taken my pregnancy test. It's positive. What do I do then?
So the first thing that you obviously need to do is make your appointment with your obstetrician of choice. And the first visit is important for us to determine, firstly, is there a pregnancy? And how many, what are the number of fetuses that we are expecting? Is it twins or is it triplets? Is the pregnancy actually in the uterus, in the uterine cavity itself, or is it an ectopic pregnancy? It could also be a pregnancy of unknown location. So you also need to, so those are some of the stuff that we need to determine at the first visit. And then a lot of counseling goes on with regards to, specific do's and don'ts, what medication you can take, what you can't take, and just in general obstetric advice, and that's basically what happens at the first visit.
I'm so glad you touched on those things. As the show goes on, we are going to talk about them in a little bit more detail, like the do's and don'ts, medications you can and cannot take. But we're going to start with medication first. So Dr. Pretorius, I found out I'm pregnant. Everyone knows we need to take supplements. When should I start taking them? What supplement should I be taking?
Okay, good question. We get that a lot. So obviously, if you go into Clicks or Dis-Chem and you look there are multiple different types of supplements, and you don't know which is what and where to start. But because we both work in the government sector, the most important supplements to take is actually your iron supplementation as well as your folic acid. And that is usually in all of those supplements that you do see at Clicks and at Dis-Chem. Some of them might contain a bit more, like magnesium or calcium or even omega. And the important thing is, to determine, you can try different types, but the main thing is just to find something that is not making you excessively nauseous or makes you vomit.
Okay.
It is a difficult choice. It's kind of a trial and error for most patients. But in general, the two important ones is your iron supplementation and your folic acid.
And those are meant to be taken as soon as you find out you're pregnant?
Yes, yeah, ideally. Most patients will have a balanced diet. So by the time you find out you are pregnant, yes, then you can start taking those supplements. Obviously, in the first trimester, it might be a bit difficult, especially with excessive nausea and vomiting. So some patients find it difficult to start it early on in pregnancy. But as long as there's a balanced diet, you can start it a bit later, but ideally as soon as possible.
Okay. You mentioned nausea and vomiting. So, Dr. Shah, I'm going to ask you. This is one of the most common complaints that any patient coming in will tell us, look, this is what happens. So, you and I both know that you can also get a point where it's very excessive. So,
Yes.
when do you know you've crossed that line that now I think, look, the nausea and vomiting has now crossed that point and I need to start worrying?
So, Tish, it obviously, if the patient is obviously vomiting several times during the day and she feels like now she is not getting to keep down any fluid or any means of hydration, usually by that time they start to feel thirsty. So the first sign of dehydration will be thirst, and if they start to feel like general body pains, muscle fatigue, headaches, which are all signs of thirst and that they are actually falling behind on their fluid, then ideally we would advise them to seek medical attention, because then they'll need to be either placed on an intravenous drip and then given some medication to help the wrenching and the vomiting, usually intravenously, and that usually does help with the symptoms.
Okay, great. So for anyone experiencing it normally, like before it's crossed that line, can you take anything for the nausea and vomiting? What's your best advice?
You can. Usually, there are a few antiemetics, which are pills that we use for nausea that are prescribed, that are essentially safe for pregnancy. Usually something like Maxilon, but we always say that consult your obstetrician first before you actually get any medication prescribed. You don't just go and get something over the counter, or let your pharmacist know that you're actually pregnant. But there are, the ASIC, Maxilon tablets, cyclizine or Valoid, and those are usually the common stuff. The non-medical components would be some might say you can try a bit of ginger tea, or a ginger biscuit, or have a cracker in the morning before you get out of bed. We usually advise smaller meals, not as greasy, so nothing deep fried, mostly just smaller amounts. If you can just keep down like small portions at a time, then that obviously helps.
Great, because
and if I can jump in there, that the majority of patients, they do get away without medication. Actually, they do, the ginger that we advise, it does help. So in the minority of patients, yes, they do need some extra medication just to get past those first 10 to 12 weeks. But usually after that, should get better.
Well, I'm so glad you touched on both of these, because you spoke about food, which we're going to talk about for nutrition, and you touched about medication. And all pregnant moms are very cautious about what they put into their bodies, because they all want their babies to grow well and healthy, and they don't want to take anything that could endanger this process. So speaking about medication, look, 9 months is a very, very long time to not have anything where you're bound to have aches and pains, you're bound to be, you get sick along the way, you want to take something. What is safe for these moms to take? Dr. Pretorius, do you want to talk a little bit of those?
Yeah, look, it's difficult because there's a vast majority of medications. So go through everything is obviously beyond the scope of this talk. But the main thing is that, analgesia, the safest analgesia or pain relief in pregnancy is obviously paracetamol. That has been studied, and we know it's safe in pregnancy in all trimesters. Later on in pregnancy, towards the second and especially the third trimester, one would stay completely away from something like an anti-inflammatory. We also don't advise that actually early in pregnancy. So paracetamol is the only one that we know is safe throughout pregnancy.
So
when it comes to...
So I'm just going to stop you. So just to clarify, if you're having a general achy pain, we're going to stop at Panado, basically.
That is the safest. Obviously, you'll individualize with each patient depending on what aches and pains they do have. Let's say it's someone that's, for example, in a car accident or fell down and fractured their wrist, then, Panado won't cut it. But for general body aches and pains, a little bit of a headache, yes, we will stop at Panado.
Okay.
So we obviously try to avoid the anti-inflammatories. And there are obviously certain periods of the gestation that, like in the first trimester, that we're a little bit more cautious with what is prescribed, because that is when the fetus's organs are developing, and lots of cell growing is still going on. So that's when you want to be extra cautious as well.
Okay. Another thing patients have asked me is in terms of antibiotics. So if they get colds and flus or they need to take an antibiotic from something, is it fine to take antibiotics?
It depends on what antibiotic they are taking and again in what trimester you are. So usually, towards the second and third trimester, a common antibiotic that we use outside of pregnancy is something that we call augmentin or amoxicillin with clavulanic acid. So that towards the end of pregnancy is a complete no-no. Earlier on in pregnancy, yes, it is a safe antibiotic to use. But again, we individualize. So depending on the patient's allergies, for example, if she's allergic to penicillin, etc., then you would avoid any of your penicillin derivatives. The main thing is, again, just to consult your general practitioner or your gynecologist prior to commencing any you ideally should not get over-the-counter antibiotics, but still, prior to commencing that, just, run it by your GP or your obstetrician and make sure that it's safe in pregnancy.
Okay. So what happens if I have chronic conditions? So I'm hypertensive, or I'm diabetic, or I have other chronic illnesses like I have warfarin, like I have atrial fibrillation. Like there's certain medications that are dangerous while you're pregnant. So are there things that you can adjust or change in those situations?
It depends so obviously, Desh, for hypertension or diabetes, there are always options available because we changed over to the pregnancy safe drugs. Obviously, then keeping a very close eye on whether we are getting control of the maternal disease. But if there is a medication that we prescribed or we use and we are cautious of what implications it might have on the fetus, and there are obviously ultrasound tests that we do in the first trimester and the second trimester that we look out for these sort of developmental errors. So we just have to keep a close eye.
So speaking about development, so diet and nutrition is very, very important. So are there specific foods that you would advise moms to start including in their diet?
So usually we say just a very healthy, well-balanced diet. We get a lot of the questions being asked about sushi. It is obviously not documented as a big no, provided it's from a reputable, company where you are aware of the fish not constantly being taken out the fridge, put back in the fridge. We advise usually not more than 2 fresh tuna steaks or 2 fresh salmon steaks per week, and also the risk of we must also be on the lookout for any risk of infection. When it comes to soft cheeses, we usually advise any soft cheese made from pasteurized milk. So that's basically the most important take-home message there. Caffeine is something we also always asked about. So can I have a cup of filter coffee a day? You can have 1 cup of filter coffee. You're allowed about 200 milligrams of caffeine a day. A cup of filter coffee has about 140 milligrams. So always bearing in mind that there are hidden amounts of caffeine in your dark chocolate, your fizzy drinks, and that sort of thing. Otherwise, a full, healthy, well-balanced diet, I think, is sufficient.
Okay.
Yeah, and especially when it comes to your cravings and stuff, because if you crave sushi, if you crave coffee, ideally we would say, if you can avoid it. Yeah. But, sometimes, it's difficult to not have your cup of coffee or to not have a piece of sushi once a week. But ideally, if you can avoid it, yes, we advise to avoid it.
Okay, great. So since we're talking about food, and on the other side of food is weight gain and weight loss. So we're going to talk about gaining weight in pregnancy, something that we take very seriously as well. Like we pay attention, we want to know how much, we want to know if you're gaining weight, because it all equivocates to a certain particular thing. So do you want to talk about what is healthy weight gain and what you should be expecting?
Yeah, so a good question. But again, it depends on what is your body mass index to start off with. If you are underweight, healthy weight, overweight, or obese. And then also if you are having a singleton pregnancy or multiple pregnancies. So average ballpark figure, I always counsel my patients, a singleton pregnancy you can expect to gain between 12 and 20 kilograms. That is on average. Obviously, if they are obese or overweight, one would not want them to gain too much of weight. Then you would, advise them between 10, 12, maybe 15. And obviously, because that also can have consequences for the rest of the pregnancy, like diabetes specifically that can develop within pregnancy. But yeah, again, it depends on singleton pregnancy or multiples, and then they start off BMI.
Okay, okay. Speaking about activities, so moms always want to know, how much is too much of work? Like, can I carry on like normal? Should I refrain from doing certain things? Is there any advice that you can give moms to be about that?
So usually, Dish, we say you should be active. We don't expect you to be a couch potato, and we always say pregnancy is not really a disease. So you obviously, as long as it's not going to pose danger to you or the fetus.
Mm-hmm.
You always have to remember that you are carrying a baby, and that should be remembered at all times. So you obviously keep away from your high risk sort of exercises. So we don't expect you to go mountain climbing or horse riding, but you should be exercising at least 5 times a week for 30 minutes a day, a brisk walk or any pregnancy Pilates or yoga. You can obviously get a trainer to counsel you for 1 or 2 sessions on what exercises he might advise that would be safe as well from his point. But it is important to be active, definitely.
Okay. So if I'm working and I'm deciding, look, I need to now take a break from working, is there a specific point that you think, I should stop working maybe 3 weeks before, a month before? Because I've been asked that a lot. When do you think I should now stop?
I think that depends on the individual and the risk of the pregnancy. So if it's a high risk pregnancy, like a patient who's had previous miscarriages or has got now hypertension in pregnancy that's not controlled, and we had a difficult obstetric care, then I would probably suggest rather stay home from 36 weeks on. It also depends on the kind of work that the patient does. So if it is a very strenuous or demanding kind of job activity, then it might be best or advice for the patient to actually maybe consider taking her maternity leave from anything between 36 to 37 weeks. Most employers anyway don't like pregnant women to be on the floor from about 36 weeks on because of the risk of going into labor at the workplace.
Okay.
Yeah, and most patients, because as you were asking about if you are working, so maternity leave is about 4 months. So most patients would want all of those 4 months rather once baby is born and not take anything before the time. Okay. So some women will work until a week before the delivery or even a day or 2 before the delivery. But yeah, generally from 36 weeks onwards, like Sumaya mentioned, they qualify for maternity leave.
Okay, great. You guys mentioned things that are very, very important. Sumaya mentioned about high-risk pregnancies. So we are going to take a little bit of a music break now, but when we come back, those are the things we're going to talk about. So if you're querying about whether you think you have a high-risk pregnancy, Dr. Sean, Dr. Pretorius are going to discuss what that is. We're also going to discuss some of the danger signs that you should be worried about while you are pregnant so that you would be able to stay ahead if something is to be wrong, and as well as delivery options. So stay tuned. We're going to have a bit of a short music break courtesy of our guest today. The next song on our playlist is going to be Emma Franklin, Piece of My Heart. We're going to join you guys in a few minutes.
Didn't I make you feel like you were the only man? Didn't I give you everything that a woman possibly can? But with all the love I give you, it's never enough. But I'm gonna show you, baby, that a woman can be tough. So go on, come on, go on. Take another little piece of my heart now, baby. Break it, break another little bit of my heart now, honey. Have another little piece of my heart now, baby. You know you got it if it makes you feel good. You're out on the street looking good, and you know deep down in your heart that ain't right. And you never hear me when I cry at night.
think one of
Good evening, everyone. It's myself, Dr. Deshni Chanan, on Medical Matters. This is where you catch me every Thursday between 7 to 8 p.m. talking about all the medical conditions you have been asking us for. Today's topic is everything dealing with pregnancy, and we have our amazing guests with us today, Dr. Sumaya Shah and Dr. Nelius Pretorius, who are obstetrician and gynecologists all the way from Cape Town, willing to share all their knowledge with us today. So remember, if you have any questions related to pregnancy, contact us on 065 4211 Alternatively, we are live on our Facebook page. You can always drop us a comment and we will answer the questions that you have. So Dr. Shah and Dr. Pretorius mentioned about high-risk pregnancies and complications. So we thought we'd talk about those today. So Dr. Shah, do you want to talk about some of the pregnancies that you consider high risk?
So there's high-risk pregnancies would be a woman who's actually got any chronic condition that we would associate with any having a difficult pregnancy, and that can entail, poor fetal outcome or poor maternal outcome. So some of the conditions would be, for example, uncontrolled hypertension, diabetes, if a patient is diabetic on insulin, poorly controlled asthmatic, as well as a poorly controlled epileptic, and any of these conditions that might now further complicate the pregnancy itself, in terms of complicating the placental functioning, as well as leading to complications that might arise with the fetus. So that would be considered high-risk pregnancies. Also, a patient who's had a previous poor obstetric outcome, or those women who've had several miscarriages in the past and has encountered difficulty pregnancies or difficulty deliveries, so that's basically.
It's a question I've always been asked is, look, some pregnancies happen later in age. Does it mean that if I'm, say, past 30, then my pregnancy is automatically considered high risk?
No, not necessarily. Age up to, the age of 35 to 38, then one would consider it being a high risk, although some institutions will go up to the age of 38 to 40 even. Just, the later on in life you get pregnant, the higher the chances of abnormalities, specifically genetic abnormalities, Down syndrome, for example, but also physical or structural abnormalities like an abnormally formed heart or brain or one kidney, etc. But age, in your early 30s, you would still be considered a low-risk pregnancy, provided you don't have any other risk factors. But age, usually the general cutoff is 38, where you are considered advanced maternal age. Although some journals, if you read some journals, they'll say 35 is actually an advanced maternal age. But in general, we tend to use the age of 38.
Okay, so some of the things that we do, what can you do to help screen patients that are high risk? Like things like amniocentesis. Patients have asked, what is it? Should I consider doing it? Is it dangerous?
So the first, usually the first step, Dish, would be counseling your patient on the different options of testing that we have available. We usually, and that would include anatomical scans. So your fetal anatomy scan is done anything between 18 and 22 weeks. And then in the first trimester, usually, we would get something called maternal biochemistry, and it's where we test for specific hormones in mom, and that guides us or points us into the direction as to what kind of pregnancy is it. Does it fall into the category of a low-risk pregnancy or an intermediate-risk pregnancy or a high-risk pregnancy? Sometimes we add to the biochemistry, we add the first ultrasound, which is called the nuchal translucency scan, and that's done anytime from between 10 weeks and 1 day to 13 weeks and 6 days. And together, these two tests can basically have an accuracy of about 85% in determining what kind of a pregnancy it is and what risk is there with regards to fetal anomalies. So the other option, if we do find that these test results come back as intermediate or high risk, then we are able to offer the patient something that we call non-invasive prenatal testing.
Yeah.
That is quite expensive, and the reason that it's so expensive is because it's got a 99.9% accuracy in determining chromosomal abnormalities. So this test would be only for chromosomal abnormalities, not for congenital or developmental abnormalities. And that usually is where we draw mum's blood and we're able to analyze fetal chromosomes now in mum's bloodstream and get a better idea. That's basically some of the tests that we're able to offer, and those are screening tests. So these tests never come back as a yes or a no in terms of a definitive answer. If some of these screening tests now screen high risk, then we move over to the confirmatory tests. And the confirmatory tests is the amniocentesis and the chorionic villus sampling. But that comes with its own risk, a risk of miscarriage and other risks. So we don't usually go straight to those confirmatory tests, not unless they screen high risk or intermediate risk.
Okay. Do you want to explain a little bit more about what the procedure is actually like, Dr. Pretorius? I've had lots of patients ask me, because I think when they read up, these are things that are common. So it would be nice to just explain to patients, if they have to go in, what to expect.
Okay. Sorry, I just missed you. Are you talking specifically about the amniocentesis?
Yes.
Okay. So again, I just want to rephrase what Sumaya said. It's just important that our listeners understand that there's a difference between screening and diagnostic test. The screening just puts you in a category to say you're either high, intermediate, or low risk, for example, Down syndrome, whereas a confirmatory test will give you the yes/no answer.
Yeah.
So amniocentesis, yes, it is still being done, but usually it's done by what we call a fetal maternal specialist, in other words, a gynecologist that further specialized in fetal medicine. So basically what it entails is, depending on their gestation, usually it's not done prior to 16 weeks, but what it entails is under ultrasound guidance, the patient will go in, she'll be awake. It's not done under general anesthetic. But what will happen is the procedure will be explained prior to that. She needs to sign consent that she knows exactly what is going to happen. But basically, in short, is under ultrasound guidance, a needle is inserted through the tummy into the pregnancy sac just to get a sample of the amniotic fluid or the water around the baby to specifically test that for chromosomal abnormalities.
Okay.
And that is then your confirmatory test, like the yes/no answer to say yes, it is Down syndrome, or no, it's not.
Okay. So we were talking about danger signs in pregnancies, because like we said, all pregnancies are very different. You never know. It's a long 9 months. Lots of different things can happen along the way. What should we be vigilant for?
So it actually depends on which part of the pregnancy or how far into the pregnancy the patient is. We can divide these into first trimester, second trimester, and third trimester. And usually in your first trimester, we're more concerned about symptoms of hyperemesis, which means persistent or excessive vomiting in pregnancy, any sort of brownish vaginal discharge or vaginal bleeding or spotting, any excruciating or out of proportion abdominal pain that might suggest, an extrauterine pregnancy or an ectopic pregnancy. That's usually in the first trimester. You do get other complaints, but these are usually more of the warning signs. In the second trimester, it's usually more very much similar to the first trimester, not much different. But any change in physical well-being would be something for concern, In your third trimester, as well as your second trimester, we would probably advise, so if there's any headaches that are not responding to Panados or simple analgesia, if there's any pain that you're experiencing in your upper abdomen, if there's any labor-like pains, or, blurring of vision, or some patients might complain of seeing stars, and that's all indicative of other serious conditions, that might occur in the pregnancy. Also, any sort of swollen calf or painful calf that might suggest what we call a deep vein thrombosis. So that also needs to be reported. And then any labor-like symptoms that might occur before 37 weeks of gestation, because that might be suggesting that you're going into preterm labor. and that's obviously needs medical attention immediately.
Okay, I'm gonna.
And especially, for your first time mums,
Yeah,
because they don't know what is normal, what is not normal.
exactly.
And we always advise, that whenever there's a concern, rather contact your obstetrician and ask, or, just make a phone call, send an email, just to know, listen, is this normal? Do I need to come in? And that we can assess that everything is still well with the patient and with the baby.
Yeah, agreed. That's the whole point of the show, is to be able to some people it might seem like very simple information, but especially for first time moms, you aren't sure. There's so many books, lots of people are giving you advice. You don't know which one is the right one, which one is not, which is why it's great to have specialists like you giving and dispensing that type of information, because it's usually the very basic information that sets the foundation for your pregnancy. So if you're aware of what you should be looking out for, you can catch things very early on, which is what we're trying to do, empower you with that knowledge. So you are in complete control of this pregnancy, so you know exactly what is going to go happen when you need to visit your doctor. And like Dr. Pretoria said, the minute you're not comfortable, you have such an intuition, and your body, somehow something doesn't feel so right, go see your doctor. You're better off getting an examination, just so that your mind is clear that everything is fine, and they can always give you the best advice going forward from there. What's really important is, there's so many different things that happen, and you spoke about pregnancy pain, and moms get very nervous about it. So do you want to explain something, exactly what is Braxton Hicks? Because people ask me this a lot, and I thought it'd be a nice idea if you could actually explain it.
So Braxton Hicks it's basically another terminology for false labor. It's labor pains that might occur that are not typical of or typically described as a contraction. It's they don't last very long as a contraction would. They're not as strong in intensity or to meet the criteria for a mild contraction, and they don't result in cervical changes or the onset of true labor, so that's basically, and it can occur at any point in the pregnancy from the second trimester on, and usually it subsides over time. That's basically
short-lived,
Why I ask is lots of moms come in with it, and then they feel silly when you're like, no, this is not what it is, it's Braxton Hicks. So the question I'm always asked is, can I differentiate? As a mom, before I come to the hospital, is there something, would I be able to know whether it's like just a Braxton Hicks contraction versus this is what's really happening, I'm having this baby?
Yeah. Well, you mentioned about intuition, and we always tell our patients as well, you rather come see me 100 times and I tell you 100
I'm
times
exactly
it's
the same.
normal, than you staying at home and, something happens at home.
Yeah, I completely concur with that. So what are some of the commonest complaints and conditions that you see, or that patients come to see you during pregnancy?
Oh, backache. Backache is the one thing that we do hear a lot about, especially, end of second, early third trimester. So that's the one thing. Early on in pregnancy, it's heartburn. Heartburn is quite significant in some patients. Nausea, vomiting, which we touched on, and constipation. Constipation is also a big thing in pregnancy, especially early on, but it can actually happen throughout your pregnancy as well. Okay. But backache is usually the main thing that we hear.
So
quite a number of patients also, complain of painful wrists, and that might be extending into the digits and into the hand, and it's not relieved by Panado, and that might be a sign of carpal tunnel. That's very common as well in some of our patients.
Yeah, it is actually very common. So my question to you is for the backache, because it's very common and I see it a lot, and we were talking about pain medication. What is my patient going to do if she comes to see me with chronic back pain and I'm like, I can give you Panado?
So
what is your best advice?
you do have other options. You can see a physiotherapist, and sometimes we need to rule out or examine the patient and see, is it just simple back pain and lower back pain, or is it actually in having nerve involvement and it might be caused by sciatica, and in that case, the physiotherapists help a great deal, and they do certain treatment modalities on you that might alleviate the pain. Obviously not much that we can give. We can offer a few stronger analgesia methods, but that would be in extreme cases, I think.
Okay, we have guests joining us online. We've got Drika Pretorius that says awesome show, Yolandi Russell that's saying great answers. We've got Paul Raju saying very informative. Thank you so much, doctors, for joining us. We also have Michelle Hubbs who's saying great information by our very own awesome doctors. Thank you very much, Dr. Shaw, Dr. Pretorius. So you've got lots of support here. So remember, anyone joining us today, we're talking all things pregnancy. If you want to get a hold of us, 065 4211 380. So coming almost to the winding to the end of the show, but there's lots of things that we still have to cover. So I'm going to get straight into it. We're now almost come to the end of our pregnancy. We now need to be thinking about deliveries. But you and I both know that delivery options should actually be thought about very early on in pregnancy and not towards the end. So do you want to talk to our listeners about the different delivery options that they have?
Okay, so basically you have two options. It's either a vaginal delivery or it's an abdominal delivery or so-called cesarean section. So we know there's enough evidence to show that a normal vaginal delivery is the best option for mom and for baby, provided that a patient can have a normal vaginal delivery. Mm-hmm. We know that some patients can't, especially patients that, for example, had a previous or two previous cesarean sections, or where there is an other indication that precludes a normal vaginal delivery, especially something like a placenta previa, in other words, where the afterbirth is in front of the baby's head. So in those extreme cases, which will also be regarded as a high-risk pregnancy, those patients can't have a normal delivery just because it's actually impossible and risky. Mm-hmm. But yes, there's the vaginal delivery also comes with its own possible complications that can happen. Dr. Shah will touch on that just now. But the main thing is that, we know that a normal vaginal delivery is proven to be the best if a patient is able to have a normal delivery.
Okay. Dr. Shah, do you want to expand?
I think as long as there is no contraindication for any mode of delivery, and if the patient is extensively counseled on short-term and long-term complications of either mode, be it a cesarean section or a normal vaginal delivery, ultimately, I think if there's no obstetric contraindication, like Dr. Pretorius said, then it should be the patient's choice. For us, obviously, if it doesn't meet criteria for a safe mode or a safe vaginal delivery, then we have to obviously proceed to a cesarean section. But extensive counseling occurs on all the visits that come up to the actual delivery itself, so that the patient is very well informed before a decision is made on a birth plan, and it's got to be reasonable.
Okay. Yeah. Now, our ultimate goal is obviously, to give a healthy mum a healthy baby, and therefore we always say we are pro safe delivery, whether or not it's a vaginal or cesarean section, as long as it's a safe delivery.
Okay. So just because I wanted to ask, patients have asked me this a lot about what are some of the pros and cons of each, because like you said, the counseling process is quite extensive. It's not enough to be able to go into it all today, but just to touch on a little bit of pros and cons about each, if possible.
Okay, so cesarean section, for example, the pros of that is you know exactly when you're going to have your baby on this day at this time. It's a planned delivery. There's no risk of going into labor, for example, because you also get patients that's got this fear of contractions, tocophobia, and they just can't cope with contractions, especially if they had a previous bad experience in one of their previous pregnancies. So the main thing about the cesarean section, you know exactly on this day, this time, the baby's going to come. But the cesarean section also comes with risks because it's surgery. We take a knife and we cut into someone. So there's always that risk of bleeding, of infection, of damage to bladder or bowel, etc. And also, in severe cases, let's say there's uncontrolled bleeding or an inexperienced person, especially in the government sector, that's doing the cesarean section, the patient might end up with a hysterectomy if the bleeding is uncontrolled. So that's obviously a severe case. Yeah. But you have to counsel patients about that, especially when it comes to the mode of delivery. Okay. When it comes to normal vaginal delivery, the benefits of that, early initiation of breastfeeding. As the baby moves through the birthing canal, the fluid gets squeezed out of the lungs, so there's less risk of transient tachypnea of the newborn, where they require supplemental oxygen. Bonding is increased, there's not this pain to get up out of the bed if the baby is crying. And again, like I think I mentioned, early initiation of breastfeeding.
then the risks of a normal vaginal delivery are also present. So you have the risks of, for example, the obstetrician has to end up have you doing an assisted vaginal delivery, for other reasons, like, if the mom gets fatigued and she's not cooperating with us, or we can see that, baby's getting distressed and we need to find some sort of way to deliver the baby almost immediately. And if mom meets the criteria, then we might opt to do an assisted vaginal delivery, and that's the use of either a vacuum or a suction cup or a kiwi or a forceps delivery. With that, also the other risks of, she runs the risk of an episiotomy during the vaginal delivery, a perineal tears, which are graded from 1 to 4. If it's a 3rd and 4th degree perineal tear, then that is involving the anus, and that would have to be sutured in theatre. So, there are risks of and benefits of either mode of delivery. But yeah, that needs to be explained to the patient very carefully.
It is a very important decision that any mom needs to decide on. And as a mom, you are entitled to ask as many questions as you want to be able to satisfied with your decision. Like we said, both have pros, both have cons, and it's really important. But you don't think about this later. You have to plan this earlier on. You have to have an idea of where you're going. It doesn't have to be something that gets sprung on you. We're in the middle of contraction and now you're deciding where to go. It's not the way to think about it. So the minute you know you're pregnant, on your visits, you need to have this discussion with your doctor. So I wanted to give advice to patients post-delivery. So things to speed up recovery or aid recovery. Is there anything that you could suggest to patients?
Early mobilization dish. So if it's a cesarean section that the mom's had, then we usually say, by the same evening, if the cesarean section happened in the morning or the next morning at least, mom should be off the bed, showered, and getting at least mobile in her room to and back from the bathroom at least. And usually, lots of support. So that would obviously, because she does need to get her rest. She does need to, because she's obviously been through a difficult journey. So that is very important, that she has adequate support. She does get in some sleep and rest. And that's where the dads come in. So an adequate pain relief, and that's basically it.
Yeah, and not to get too despondent when they, struggle with breastfeeding, because that's also something that we see quite often, that patients get so despondent when the breastfeeding is not working. And, just, give it time. And, if it does not happen, there's always means that we can help the breast milk, but to come out. But the main thing is, for some patients it just does not work, and that's okay. It's not the end of the world. It's okay.
It really is. So we try to counsel quite often, and we've even had pediatricians come in to talk about the breastfeeding. Anxiety is one of the things that actually affects breastfeeding in the first place. To try to understand it's not a thing that just occurs. It's something that you have to try, and babies take some time to latch on, and they need to be coaxed a little bit to get on board with you.
Yes.
So it's also about being patient with yourself, and it's a journey that you've already been on. You've got a while to go. Enjoy the experience, even if it takes you a little bit longer than you anticipate. And every person's pregnancy is different. And I think, seeing, it happened early on for a friend of mine doesn't always seem to work. You're on your own journey. Just go with the flow, see how it goes. And like you're saying, there's lots of ways we can help and aid you along the way.
Yes, enough rest.
Yeah.
And a good diet as well.
Yeah, your body's been through a lot. You need to pace yourself through it.
Yeah.
Absolutely.
So I actually do have a question here. So a patient wants to know about epidurals, and if you've had them, what exactly is it doing when you have an epidural? When can it be given? And if you've had multiple epidurals, is it okay to take another one? Like, say you've had multiple pregnancies.
So an epidural is something that the anaesthetist will usually counsel the patient about. It's usually given in labor. It depends on the obstetrician. Most obstetricians would advise that an epidural be given only from about if the patient is from about 3 to 4 centimeters dilated, so that we allow that in the early latent phase of labor, the patient is still able to mobilize, and that obviously helps also with the delivery itself. An epidural is usually a form of pain relief that is given where it's actually an injection that's given into the epidural space, and usually analgesia is run via that tubing into the epidural space, and that provides enough pain relief. But with the epidural, mom is not able to walk, and she's not able to control her urine. So then usually a urinary catheter is inserted. And that's usually the epidural is run throughout the active phase of labor, and then until the delivery is done. Some obstetricians might opt to slow down the epidural from the time the patient is fully dilated to aid with mom being cooperative with us, to use her contractions adequately and able to, push properly when it's time for bearing down. But that's basically what an epidural entails. Can you have too many epidurals? I don't know. You can't. I don't think so. I don't think you can.
I've never heard of too many epidurals, to be honest. Maybe, the question must rather be, don't have too many children in today's age. But there's, from our anesthetic colleagues, I've never heard of anything about too many epidurals.
Okay, that's great. Guys, we have come to the end of our show. It's been a very, very fast hour. I was actually very eager to do this conversation with you. You've had lots of questions that are very commonly asked. I hope to those of you that are listening that today has been beneficial, and it's actually alleviated some of the anxiety that you might have had associated with pregnancy that you might be going through. And remember, you can always get a hold of us at any time, 0654211380. If there are any topics that you think are interesting and you would like us to talk about, feel free to contact us and we will get those specialists on to be able to discuss the conversations that you want to hear about. Dr. Shah and Dr. Pretorius, thank you very, very much. It has been very interesting to have both of you here, and I hope the experience was as pleasant for you as it was for me.
No, definitely. And can I just say, I'm very glad for this, and also that you asked her most of the questions, because I'm the pretty one, but she's the clever one.
It works out as a great team, but we alternated, so both of you got to say exactly what you wanted. But it's been incredible.
Thank you, Desh, for having us.
No, it's been such a pleasure. To everyone that's listening, thank you guys for joining me. You know this is where I am every Thursday between 7 to 8 p.m. Medical Matters on Capital Radio. You can always get a hold of us on 0654211380. Alternatively, we are streaming live on our Radio Garden app as well as our Mixcloud account. And you can always catch me here every Thursday. So remember, wherever you are today, be safe. Remember social distance, wear your mask, take care of yourself, and we will see you next week. I'm going to leave you with the rest of the playlist. So the next song we're going to have is Adele, Set Fire to the Rain. And I will see you guys next week. Cheers. Bye.
Bye.